And again, while we're getting seated, I want to thank our sponsors, particularly our silver sponsor, MedBill Resources, and thank you for visiting the other vendors and exhibitors in the hallway. If you signed up out front and did not get a ticket for the door prizes, please stop in the booth in the back in the hallway and get your ticket. Door prizes will be posted throughout the throughout the day, and you pick up your prize in the back corner back over here. Dr. Mehta, you ready? It's with great pride and pleasure I get to introduce our next speaker, Dr. Mehta. He is an interventional cardiologist at Grant Medical Center and part of the Grant Medical Center heart team. He's also the community outreach medical director. He's going to be speaking today on what you see may not what you get, and it's myocardial infarct imitators. Please welcome Dr. Mehta.
Good morning. Can you guys hear me? Okay. So today what I'm going to talk about is something a little different. I think I've been here the last few years where we've talked about a lot of different things, acute coronary syndrome, heart failure, and then STEMIs. But today we'll talk about something a little different, basically things that may look and sound like an infarct, but they really are not. So some of this is going to be review. Some of it hopefully will be a little bit informative for you. So two different ways that myocardial infarction can present. Obviously, EKGs can be abnormal, and then clinically, people can have presentations that may be suggestive of MI but are really not an MI. So what I'm going to do first of all is just kind of go through some basic EKG findings. And what we're going to start with is here's just a normal EKG. And you can see nice normal sinus rhythm. Hit the wrong button. There you go. Nice normal sinus rhythm. And what we'll try to do is divide this up into different territories, because obviously when people are having a heart attack, they're not going to have a heart attack to the entire heart. It's going to be specifically in certain distributions. So here's the basic anatomy of the heart. Here's your right coronary artery, courses around back, and then sometimes gives off the posterior ascending artery. Here's the left main trunk, forms the left anterior descending artery, and the circumflex, which can 85% of the time only supplies the side of the heart, but 15% of the time it will actually also supply the posterior aspect of the heart. So when we look at our EKG, I want you guys to kind of be cognizant of this, is that this is going to be 1 in AVL, and this typically is going to represent your lateral leads. So if someone is having a lateral infarct, they're going to have changes typically in 1 AVL, which would correspond with the circumflex artery. The inferior leads are going to be 2, 3 in AVF, so any sort of inferior infarct will have ST changes in these 3 leads. And generally when we define an MI, it's going to be greater than 1 millimeter of ST elevation in 2 contiguous leads. So if somebody has ST elevation in 1 and 2, they're not necessarily contiguous because one's a lateral distribution, the other one's an inferior distribution. So whenever you're looking at these EKGs, when you guys are out in the field, just start to kind of bunch these things together. Lateral, 1 in AVL, inferior is 2, 3 AVF, and then the precordial leads, we start anterior septally here in V1 and go towards across the anterior and then anterolateral. So sometimes people have a big circumflex or they're having a big diagonal infarct. They actually have ST elevation, V5, V6, and 1 in AVL. So remember, when these infarcts happen, they're going to be geographically connected in terms of different leads. So just a brief review. Obviously, here's nice sinus rhythm. You can see the precordial leads, the classic tombstone ST changes. This is an LAD infarct, anterior MI. These are all going to be chip shots. So here's an inferior MI. You'll see ST elevation 2, 3 in AVF. These are reciprocal changes in the lateral leads. And even here, whenever you see an R wave that is bigger than your S wave, that's when you want to think of posterior or RV-sided infarcts. And here's your lateral MI, where you will see ST elevation in one AVL, reciprocal changes in the inferior lead. So you can see how any sort of ST change, if it is an infarct, is going to be very geographic. So here's lateral, here's some lateral changes here, and then any reciprocal changes will be in the opposite side of the heart with ST depression, and everything tends to be geographically clumped. So now what we'll do is talk about some different ST segment changes that can occur just in normal situations. Now this is a terrible slide for you guys to read, but what I would tell you to do is if you have access to the New England Journal of Medicine, 2003, this reference down here gives a nice little review about some ST changes in normal situations. But here I'll show you some different examples, but I'll kind of run down the list for you in the meantime. And I think Mr. Ludwig had a great conversation that less than 1% of all that you guys see is a cardiac arrest. So there will be millions of runs that you guys make for chest pain, and about 10 to 15% are truly acute coronary syndrome. So to be aware of non-cardiac causes of chest pain and even EKG changes that are not truly coronary, it's important for you guys to know. So what we did before is show you what's abnormal that does represent an infarct, and hopefully now we'll talk about some things that may be abnormal but do not represent an infarct. So there is actually a normal EKG in young men. They said 90% of the time you'll have some ST elevation across the precordium. We'll show you some examples of that. Early repolarization, left ventricular hypertrophy, left bundle branch block, pericarditis, elevated potassium, Brugada syndrome, pulmonary embolus, and actually after regular cardioversion, there can be upwards of 10 millimeters of ST elevation just after transthoracic cardioversion, which is temporary. And some of that is supply and demand mismatch after you've converted somebody. Somebody just may have some issues acutely. So here is basically all different ST changes that are still somewhat normal. So you can see that there is some ST elevation here in tracing one. This is so-called that early male normal variant. They'll have some degree of ST elevation in the precordium. It doesn't have the classic concave or tombstone findings that you'll see in an acute infarct. One thing that I am going to stress during this is sometimes just use your common sense. You get an 18-year-old guy with chest pain to get this EKG, the likelihood of him having an acute LAD occlusion is extremely low. It still is there, probably less than 1%, and some of these things just may be normal variant. Here you can see this notched concave up ST change. This is classic for early repolarization. This is going to be something very common in young African-American gentlemen, but basically there's just going to be this ST segment with a little notch right at the J point that is consistent with early repolarization. And then tracing number 3, this is another normal variant where you do get this different deflection. Doesn't look like that classic tombstone finding. You'll see a little bit of flattening right at the J point, and then even this T-wave inversion is still considered normal variant. We actually, the ER docs at Grant are great. If they have a question, they're very good about faxing us an EKG. And there have been plenty of times in the middle of the night where they'll fax us an EKG on a 25-year-old kid who's pretty athletic, comes in with squirrely chest pain, and we say, you know what, that's normal variant, and that's okay. We don't have to come in the middle of the night to cath them. So now these are going to be ST segment changes that are a little bit different, that are still, I wouldn't say they're normal variant. They can be in different disease states, but are not necessarily a STEMI. And unfortunately, kind of got to follow it down going vertically. So here in the first panel is going to be, you can see that there's a lot of voltage. So what do EKGs do? They measure electrical charge. So if somebody has left ventricular hypertrophy and they have a thick left ventricle, they're going to have more voltage. So this is a classic EKG for LVH. There's probably about 30 different criteria if you want to quantitate LVH by looking at different leads and looking at different criteria. One of the most common, which isn't listed here, is actually going to be an AVL. Anything, an R wave bigger than 11 millimeters is one of the most specific ways of documenting LVH. Here, when you look at this, you look at V2 and V3, you add those up, and if you get more than 30, 35 millimeters of voltage, that can be a diagnostic criteria for LVH. And literally, if you look it up in some EKG textbooks, there are nearly, like I said, 30 different criteria to document LVH. Panel number 2, anyone want to take a stab at it? It's kind of hard when you only get 3 leads, so I'll give you a break. This is a left bundle branch block. I actually have a 12 lead going over that. We'll talk about it more when we get to it. Lead 3. Anybody? They actually, the article actually quotes this as a pulmonary embolus. Now, in 10 years, I've never really seen a pulmonary embolus have ST elevation in the inferior leads, but apparently there are some cases of that. Lead 4 is Brugada syndrome. They have RVH with this, they have a right bundle branch block with this notched pattern that may be suggestive of that. This one is going to be post-cardioversion. You get that ST elevation across the precordium. Oh, I apologize, this one's Brugada. This one, I have to double check what that one was. So here is LVH, normal sinus rhythm, big voltage across the precordium. If you think about it, V3, V4, V5, V6 measures voltage across the left side of the chest, where if you have a thick left ventricle, you're going to get more voltage. So you can see that the R wave here is bigger than usual. This is going to be LVH. They're going to have these repolarization ST depressions that are consistent with repolarization. This obviously is not going to be a STEMI. If this person was having chest pain, you'd have to say, cannot rule out ischemia. Here's another one, LVH, based on voltage criteria. These deep T-wave inversions are all suggestive of repolarization. Once again, if this person was complaining of frank chest pain, you'd have to kind of do that medical legal cannot rule out ischemia. But I think that these, when we look at this, when you see the big LVH here, the big voltage in the precordial leads, that would be consistent with LVH. So here, and believe it or not, the number of STEMI alerts that have been called for a pacemaker, it probably have had 3 or 4 in the last year. But basically, you look at this nice sinus rhythm, you can basically make out a notch just before this QRS complex. There is ST elevation, but anytime you have a pacemaker, that's an indeterminate rhythm for us, meaning you cannot diagnose a myocardial infarction when you have a paced rhythm. This EKG change is too abnormal for us to say anything is going on. Even if they have a stress test and they have a paced rhythm, we say that that's an indeterminate EKG, and you cannot diagnose ischemia or infarcts based upon this interpretation. And here's just another example of AV sequential pacing. There's your A notch, there's your V notch, and you can see the ST changes that occur just from the pacemaker activation. You see that there's ST segment elevation, very dissimilar like a left bundle branch block, but basically this is an indeterminate, non-diagnostic 12-lead EKG. So here's your left bundle. Looks very similar to your paced rhythm. Anytime anyone presents with a left bundle branch block, this is also an indeterminate EKG. We can't make a comment one way or another about infarct or not. Anytime, though, anyone presents to the ER with complaints of chest pain and they have a left bundle that we think is new, we actually treat them as an infarct. So if this person shows up with chest pain, last EKG 5 years ago at the hospital was normal sinus rhythm, we actually would take them straight to the cath lab. So anytime I meet a patient and they have the left bundle branch block, we actually say, make sure you tell, next time you call the squad, next time you go to the ER, make sure you know that you have this left bundle thing, because then you take that with a grain of salt when you interpret their EKG finding. There are a lot of different criteria out there. There's one where it says if the ST segments are 5 millimeters above baseline in the setting of a left bundle, you can call that a myocardial infarction. I've never really been one to believe in that, because there are some EKGs where there's ST elevation that's right here. You can see that this is nearly 7 or 8 above baseline. You cath this person, their coronaries are normal. Probably they've had some sort of cardiomyopathy. There's only one real time where you can look at a left bundle and suggest that there's ischemia or an infarct. And I'll show you that next. But here, basically, when you look at a left bundle, you can see the QRS is downward and the ST segment is going the opposite direction. This is what we call discordance. Discording meaning obviously they're not in a parallel. So here the ST segment is going upward, the QRS is going downward, and that's fairly consistent even out here in the inferior leads and in the limb leads. The QRS segment goes opposite of the ST segment. And so the time that you can call a left bundle with ischemia is going to be when you have concordance. So this is something that not everyone knows, and it's a great little pearl, that when you have a left bundle with the QRS segment going one direction, and if your STs go the same direction, you can call that acute ischemia or an infarct. So you can see here, V1, V2, V3, there's discordance, but when you look out here, V5, V6, and in the lateral leads, and I apologize, the EKG is in a different order, you can see that there is concordance where the ST segments are going the same direction as the QRS. So this is a left bundle branch block with concordance, probably having a lateral infarct. Okay? So now clinical presentation, and this is where Mr. Ludwig, he himself said it too. Talk to your patient. Ask them a lot of questions. A lot of times you can determine a lot of things just based from asking them questions. What's new or different in the last couple weeks? Any recent trips? Any new medications? Anything that you should have been doing that you're not doing, or anything that you are doing that you shouldn't be doing? And any past medical problems. If they are presenting with chest pain, and you've had this before, what did that feel like? What did it end up being? A lot of times when I even talk to patients and they're having angina, and they've had a previous event or they've had previous surgery, I ask them, what did your old heart attack feel like? Is this same? Is this different? If it is different, I do agree with Mr. Ludwig that I do feel better, that it's not necessarily ischemic in nature. But basically, when you go through each one of these, pericarditis, myocarditis, well, what's the difference? The difference is pericarditis is just inflammation of the sac around the heart, whereas myocarditis can be inflammation of the muscle associated with the sac around the heart. Pericarditis typically doesn't have abnormal cardiac markers, but I've cathed many people who have positive enzymes, so they would have had a heart attack, but their symptoms are very suggestive of pericarditis, but you almost have to cath them to say it isn't a coronary event. Basically, pericarditis, myocarditis, age varies. There's no age predilection. The biggest thing is I always ask people, have you had a cold recently? Or have you had diarrhea, any sort of viral illness? One of the most common viruses associated with this is Coxsackie virus, which is a GI virus. They'll have diarrhea, and 1 to 2 weeks later, they'll have this pleuritic type chest pain. History of rheumatologic disease. Lupus, rheumatoid arthritis, all these rheumatologic disease states will have some sort of serositis. So serositis basically means inflammation of the linings of the body. They can have pleurisy, they can have pericarditis, have plenty of patients who present later on, it's an inflammation of their lupus, and they do have some pericarditis at the same time. Recent chest wall radiation, if they have a history of malignancy, sometimes some malignancies will actually spread to the pericardium where they get a malignant pericardial effusion, and with that, they will have some irritation and some inflammation. If they have a recent heart attack, say, is this pain similar or different? But even then, after heart attacks, people can have pericarditis. There is a thing called Dressler's syndrome, which is post-myocardial infarction, inflammation of the pericardium, where basically they'll have chest pain. It's different than their MI. They may have some EKG changes, but typically it gets better with non-steroidal anti-inflammatories. Same thing with bypass. You cut open a heart sac, there may be some inflammation afterwards. They also will have some symptoms of chest pain. And once again, ask them if it's similar or different. Typically, pericarditis, myocarditis sounds very much like pleurisy, except it's not going to be right-sided, it's going to be left-sided. It's a sharp stabbing quality, almost like someone sticking a knife in their chest. It is worse with a deep breath, twisting and turning of the torso. One little pearl, if you do have pericarditis or even pericardial effusion with pericarditis, that pain will radiate to their shoulder blade. The phrenic nerve, which is our nerve that goes to our diaphragm and kind of cuts across the back of our chest, it goes right next to it'll have referred pain to your shoulder blade. Any irritation of that pericardium will irritate your phrenic nerve. So a lot of times that chest pain will radiate to their left shoulder blade. A lot of times certain positions can improve pericarditis. It may get better when you sit up or lean forward because you're taking the pressure off the pericardium, but it is worse than when you're lying flat. So the EKG changes with pericarditis. Classic is diffuse ST elevation, and you'll see here there's ST elevation in 1, in 2, 3, AVF, and the precordium. Obviously this person is not having a heart attack to every vessel of their body. But when you have this ST depression and they have that classic story of sharp stabbing chest pain worse than they take a deep breath, we worry about pericarditis. The other pearl is that they will have some degree of PR depression. You can see right here, here's your P wave, here's your QRS complex. That P wave is depressed, that PR segment is depressed from their baseline. That's not always going to be present, but that is something that points more towards pericarditis. Like I said, I've cathed people in the middle of the night who've had this sort of ST depression, and this ST elevation, and they're so sick that unfortunately you're kind of stuck, and you have to cath them to say that it's not an infarct. Pulmonary embolus, not necessarily a classic story like angina or a myocardial infarction, but a lot of times people don't always have the classic story themselves. One thing that when I've been out on the speakers tour is we talk about women in heart disease, we talk about elderly patients and diabetics who don't always have chest pain going to their neck, jaw, and back. A lot of times people can have shortness of breath as their presenting sign of their myocardial infarction. So obviously pulmonary embolus, depending on thrombus burden, can have some degree of shortness of breath. They also may have chest pain. It'll be a pleuritic component to it because when they do have pulmonary emboli, they can have infarcts to their lung, so that'll cause a little bit of pleurisy, give them that same sort of inflammation, sharp stabbing pain, worse with a deep breath. Then of course, depending on how big their pulmonary embolus is, they can be diaphoretic, cyanotic, and they can get hypotensive. So some people with PEs can get really, really sick, where it may be a presentation just like a big old infarct. So history for you guys when you're asking them questions, any recent trips. Obviously, if you've taken a 8-hour car trip and you weren't up and about walking every couple hours, you can be at a predisposition to having a DVT. Pregnant women who tend to be more hypercoagulable can also have DVTs. There's a history of cancer. Very, very common. People have cancer and are laying in bed after they get their chemo or their radiation, can develop a DVT faster than most people. If they've had trauma, if they were playing tackle football and they got a big Charlie horse on their thigh from getting hit, if they sit around, that sort of trauma to that vessel can predispose them to having a DVT. Then of course, postoperatively, they can be at risk for pulmonary embolus. So the classic story you read in every single textbook in the world for an EKG and a pulmonary embolus is S1, Q3, T3. Never seen this. The most common EKG finding you see when you have a pulmonary embolus is, anyone? Take a guess. Sinus tach. Sinus tachycardia without any significant EKG changes is going to be your #1 most common EKG finding when you have a pulmonary embolus. Any sort of lung issue can cause this S1, Q3, T3, which is a sign of RV strain. So when it comes to PEs, EKG doesn't do you much good. It's a poor diagnostic tool. Here is an example of your S1, Q3, T3. I found it off the internet. Basically, you have a S1, Q3, and then T3. You see the T is inverted, the Q lead, and the Q in lead 3. Basically, this is pathognomonic for RV strain. There's even a right bundle branch block here in V1. You see kind of the little RSR prime. That can be a sign of RV strain or RV overload. But the most common EKG finding in pulmonary embolus is going to be sinus tachycardia. And here's just sinus tachycardia. So hyperkalemia, this is going to be something where asking the patient a lot of questions is going to be important to you. There are times when people can have ST elevation in the setting of hyperkalemia. The most common sign is going to be peak T waves, and I'll show you an example of that. But the history is important. They may have a history of chronic kidney disease where they missed a dialysis treatment or two. Typically, most of these renal patients are so used to having a high potassium that if they missed one dialysis run, it's not going to cause a whole lot of trouble. But if they have missed 1 or 2 or 3 treatments, there may be some evidence of elevated potassium. New medicines from a heart standpoint, because that's what I do. Anytime you see a new ACE inhibitor, there's about 10 ACE inhibitors that end in the word pril, lisinopril, quinapril, enalapril. Those ACE inhibitors can cause hyperkalemia. It can be within 1 to 2 weeks of a new medication. Same thing with angiotensin receptor blockers, anything ending in sartan, so there's losartan, olmesartan, candesartan. Any one of those medicines can cause acute hyperkalemia. And then spironolactone or aldactone. These are potassium-sparing diuretics. If anything, they can cause elevated potassium. If that's a new medication, it can cause hyperkalemia. Typically, when you get an EKG on one of these hyperkalemic patients, you're going to get this peaked T wave in the precordium, not necessarily an ST elevation, but this is also a finding that you see in hyperacute myocardial infarctions. Whenever someone is having a heart attack, there's cell death, there's elevated potassium locally, so this can be a sign of a subacute MI. Here's another one where there's ST elevation in V1 and V2 that may be concerning for Brugadas or even ST elevation infarct, but this is really just due to hyperkalemia that you can dialyze it off and they'll get better. So here's one that commonly is called an acute MI. This is an old infarct with aneurysmal change. Here's a strip where rhythm is atrial fibrillation. You see ST elevation in V3, V4, and V5, and you can see it kind of has this soft, rounded curve to it, not classic for the tombstone. The other telltale sign is that there's not good R wave progression. So if there was a good R wave in V2, V3, V4, and V5, that would be more consistent with their still living myocardium. But when you have a poor R wave or even a Q wave, that often is a sign that there's already been an old infarct, and that ST segment kind of, this curvilinear shape to it, is more suggestive of aneurysmal change. This is a guy actually admitted to me what's called a STEMI down at Grant, and before I cathed him, based upon this EKG, he was really not having much chest pain. You can see that there are no R waves in V1, V2, V3, V4, and he kind of has this ST segment elevation that when we cathed him, his LED was occluded, and it was actually filling with collateral flow. So this guy, as much as he's had an old anterior infarct, it wasn't acute. So when I cathed him, we saw that his LED was occluded. We actually left things alone because he actually had good collateral flow. And when I say aneurysmal change, the tip of the heart can, when it dies over time, kind of balloon out like an aneurysm, and that can put people at risk for having blood clots and strokes. And here's just a comparison, just to kind of help you see some of the differences between acute infarct and old change. You can see how these ST segments are quite impressive in terms of those changes. These are not quite, although albeit somewhat impressive, they just don't have that same shape to the ST segment. And the big thing, like I said, is you're looking for that R wave. There's an R wave bigger than the S wave here, which tells us that there is viable myocardium. Here there is not any good R wave. There's not any good R wave here to suggest that anything is still living underneath it. Any questions so far? More of a review. So here's, actually we're coming up to the end of our talk. Here's a case presentation, 35-year-old healthy male who completed the Columbus Marathon and subsequently collapsed. EMS on site came, found the patient. He was in pulseless VFib. ACLS protocol was performed and normal sinus rhythm was restored. Hopefully you can see this. This is actually, I'm sure some of you have read in the paper, this is a guy who's down at Grant. A couple Saturdays ago, here's his EKG, and I kind of already let the cat out of the bag, but here's an RSR, and these ST segments here are classic for Brugada syndrome. So he was someone who came to Grant, spent time, had the hypothermia protocol, and is actually going to get his defibrillator later on this week. So for the guys who are out there who brought him in, a little follow-up for you. Last but not least, here's an elderly gentleman who presents with chest pain. He feels that he's anemic, is requesting blood. He denies any past medical problem, but is having complaints of chest pain. Here's his EKG, looks nice and normal. But the point of this slide is use your common sense. Not everyone who has chest pain is always going to be an acute infarct. Sometimes it can be the obvious reason. Review. Many complaints of chest pain may sound coronary in nature. EKGs can be helpful. They can be harmful. Most importantly, history is important. I think when you guys are out there and you ask your 10, 20 questions, ask some of the ones that are more guided, and you can get a good sense of if it really is cardiac or non-cardiac. Use your common sense. One thing that we've really been impressed with is you guys who transmit. You guys are transmitting your EKGs. That has really cut down the door-to-balloon time, and it helps us to kind of have a sense of what's going on as we're coming in, because those do come to us all personally. And more or less that's it, but I wanted to give a plug to you guys. This was in the dispatch a few months ago, that now with what EMS is doing to help streamline heart attack care, by you transmitting EKGs, are really cutting down our door-to-balloon time. And just, this is more a plug for Grant. When you look at this, the national time should be 90 minutes, door-to-balloon. Most Central Ohio hospitals, Ohio State, Riverside, have 52 minutes. And at Grant, we did average 48 minutes. And I did see in the slide that I think we're down to 44.6 minutes for our door-to-balloon time at Grant. So that's basically it. It was pretty quick. Little review of non-cardiac causes and EKGs. Do you guys have any questions for me? All right, that's it.
Thankful that OhioHealth and Grant Medical Center have put this on for the last couple of years because it's a great kickoff for EMS week. And certainly to see so many people attending, I think it's a wonderful accolade for our community in general to have a conference like this, and in particular to have the John P. Moore Award given today to Lieutenant Cosmer. John Moore was a good friend of mine. He epitomized excellence in EMS care. He was passionate, and he really did care about EMS. So it was great to just see this, and I thank everybody who put that together. As Rick alluded to, I've been around for a while, and a couple things I've noticed in my years in EMS here in Columbus. One is that if you're an EMS provider, be thankful that you're working in Columbus. And I'll tell you why. First of all of our hospitals play well together. And I'm glad that we have 3 hospital systems here in the community as opposed to just one kind of megalithic system, because it keeps you sharp when you have to compete against other facilities. And so I think it's a good culture for EMS to thrive in. And I also know that we're fortunate because we're on the cutting edge of EMS in general across the country. So we've got problems, sure, things that we could do better, but by and large, I think we're pretty lucky to be able to practice our craft in a community and in a culture that really welcomes excellence. The second thing I've noticed in my years is that I have found very few drugs, very few pieces of equipment that have really had a major impact on patient outcome and survival. But I have noticed that system changes seem to make the most global differences. One of the most significant wins that we've had here in Columbus is our STEMI system. When we implemented that with 12 EKGs that could be transmitted to emergency departments, and then having interventional capabilities at most of our hospitals here in the area, I think that has saved countless lives. And again, the competition is good, because when one of my crews brings a patient with a STEMI in to an emergency department that doesn't take them immediately to the cath lab, they're on my phone in about 10 minutes telling me all about it. And so we have an opportunity for improvement. And then when we bring somebody in who's having a STEMI and we haven't sent the 12 lead and we haven't given notice, I hear about that too. And so we have an opportunity to improve. So again, be thankful that we're operating here in Columbus. We've got a good system. And also, I'm going to talk about a system change with you that came about not through any kind of, epiphany or any kind of scientific study, but we had one of our firefighters that identified a need, and he pressed into that and got all the people to cooperate, including myself. And I think we've come up with a pretty good solution to the problem. So I'm going to talk about that. And the question is, have you ever been in a situation where you have been at a loss to know what to do in an EMS setting? Now, most of the time, we've got protocols that kind of drive our treatment. You're having chest pain, we do the 12-lead, O2 aspirin IV. You know, we have a trauma, we pretty much know what we're going to do. Asthma, a child. We have it in our mind what to do, but there's those very isolated incidents, and they don't happen very often. But when they do, they really cause the hair on the back of our necks to stick up and think, you know, my gosh, what would I do if this scenario presented itself? So even though it may never happen to you, is every patient able to be extricated? And I mean no disservice or disrespect to our fine rescue personnel out there. I know they can get people out of a, you know, soft drink can if they had to. But, you know, is every person able to be extricated? And if not, and you're in that situation and the clock is ticking, who do you call for help? And will they be able to come if you call them? How can you get a hold of them? And if you do get a hold of them and they want to help you, but their lawyers object, I mean no disservice to lawyers either, how do you get them to the scene? And when they do come, what are they supposed to bring with them? Who's in charge of the scene? And finally, when you're in the throes of a critical situation like that, do you really want to be asking those questions? And I think not. So, I'm going to give you a little overview of Columbus Fire. You may or may not know these statistics, but we have 34 engines, all of them ALS, with at least one paramedic on each engine. And we have 32 medic vehicles, which are our transport mediums, with 2 medics on. We have 15 ladders, 5 rescues. We have 7 battalions in the whole area, and 7 EMS supervisors or officers. It's an all ALS system, and so every time 911's called, that caller will get a paramedic, at least 1 right away and 2 to follow. And those are our incidents from our annual reports. And so as you can see, you know, we are a fire service, but 80% of what we do is EMS. So I'm going to give you a little history first about the types of situations that might require a surgical emergency response team. So one of the surgeons for Napoleon back in the day was a very much of a favorite of Napoleon. He was a brilliant physician and surgeon named Dominique Laurie. And he actually came up with the idea of having what they called flying ambulances, which really were just horse-drawn carriages that would take 4 to 6 casualties at a time, kind of lying in parallel to the field hospital. So this was kind of the precursor, really, of EMS. And so if there was insufficient, you know, transport vehicles, then they'd just take them in wheelbarrows. And the civilians would push the wounded soldiers to this field hospital. And the concept of the field hospital was also something that Dominique Laurie came up with in that, as Napoleon was marching on and conquering all his lands, they needed to have mobile hospitals that would actually be in the field of battle so that they could take care of these patients and not let them bleed and die. And then finally, you know, with nothing else to do, he actually came up with the concept of triage. And so the wounded were treated according to their need for treatment, and not because they happened to be a duke or an earl or some other, you know, landed gentry that was wealthy, and then the other kind of serfs and servants were not taken care of. So very much of an innovator. And of course the Civil War was another field in which we continue to modify these on-scene procedures, most of them being amputations in some of the field hospitals that were set up. Now, when you look at the scientific literature in terms of incidents where you had a situation that couldn't be immediately remedied by the EMS providers and their equipment in the field, there's not a whole lot out there as far as the case reports. One of them happened to involve a 28-year-old man who was in a semi-trailer accident, and very tragically, his wife and daughter were in the vehicle and the daughter died. He was wearing a seatbelt, but his legs were trapped by the actual dashboard. And he was trapped for about 7 hours, and the rescue personnel, for whatever reason, they just weren't able to get him extricated. So they decided to kind of jury-rig some sort of scene response. So they called a surgeon and a nurse from a nearby hospital, and they were airlifted to the scene. So as you might imagine, after all this time passed, the patient was deteriorating, so the decision was made to do a bilateral below-knee amputation. Well then, once they decided to do that, they said, oh yeah, we need an anesthetist and we need blood. So then they were airlifted. Secondary to that, time is ticking away. Patient was intubated and anesthesia was applied. They did one BKA, and then they tried to get the patient out thinking that maybe that's all we'll have to do, but then they had to do the second one. They used thigh cuffs and belt for tourniquet, and this was actually occurred up in Toledo, so I went to the Medical College of Ohio. 5 months later, the patient was doing fine and actually survived the incident. So this case report proved the feasibility that you can do an amputation at the scene, but you need to have careful arrangement for all that stuff to be available in a timely fashion. And so level 1 facilities needed to be prepared for that eventuality. The second case involved something in the rural area, a couple of cases. One involved a patient who's had his left arm caught in an auger. And so this machinery was actually bolted to the cement floor, couldn't be disassembled. So they brought a surgical team from a nearby hospital, and it was a 60-mile ride going 90 miles an hour to the scene. And at the scene, they were able to start an IV. They actually had to kind of morselize or kind of just cut away the remaining part of the arm. And they were extricated, minimal bleeding, and transported for definitive care. The second patient had a silo fall on him. And in this case, there were lots of different things going on, including flammable gases that could have been ignited by some of the rescue equipment. And so also the patient access was a problem. Scene safety came into play. They actually flew a team out to take care of this patient. And once the patient was removed, he was taken to the hospital and had some amputation sites repaired and some compartment fasciotomies done. So not a whole lot in the literature about this. And the reason is because it doesn't really happen that often. Now there are cities that have put these things into place, but if you've seen one EMS system, you've seen one EMS system. So it's not apples to apples in any way, but a couple of the examples include Los Angeles. They have something called the HERT team, which is the Hospital Emergency Response Team. And this is a team that's flown out in a helicopter. And actually, if you remember that horrible train crash that occurred in Los Angeles years ago, their medical director, Mark Eckstein, actually was nearby and drove to the scene, and this team was assembled to go and take care of the victims. So they have something like this in place. So does Miami, down in Broward County. They have a team and a protocol in place. And finally, Maryland, through the Shock Trauma Center there in Baltimore, they have a team that's flown out in sheriff's helicopters to take care of these things. But we didn't have anything in this community. Some of the things you want to think about when you have a team like this is scene safety. You know, are there flammable gases around when you get the surgeon and the team there? Are there live electrical wires? What's the crowd doing? Are there enthusiastic rescuers there that shouldn't be in the mix? And do you have to kind of stabilize some of these unsteady structures before you actually send a team in to help them? So protect the team, bottom line. Informed consent. I mean, what do you do when you have someone who's got, a huge object on their legs and you're wanting to cut the legs off? Do they go ahead and say, yeah, go ahead and cut them off, get me out of here? Are they awake? Are they a child? Are they not able to give consent for whatever reason? And who's liable? Obviously, the question always comes up with any kind of health care, but who is liable for these procedures? If you're going to transport a team 90 miles an hour down a freeway to get to a scene and they crash, well, who's liable for that injury or for that death? What about the transport from the hospital? And of course, the question, or the answer to the question, can we get sued for anything at all, is always what? Yes. Yes. You can get sued for whatever. Whether you'll actually have an award given or whatever, but you can always get sued. What if communication breaks down? What if competence is in question? So this all came to light in an incident that occurred here in Columbus back in 2010. And I'm going to take you through that incident so you kind of get a flavor for what was going on with this. But the call came into the FAO, rescue incident, man trapped in a machine. And so that was on January 8th, 2010. So the first arriving companies got there in less than 5 minutes. And what they found was a 25-year-old who had become trapped in an industrial mixer. Now, I did contact the company about this and asked if I could get some pictures of their facility. And unfortunately, they're going through an OSHA review right now. I think there's a lawsuit, so they were not cooperative, and I understand why. So, I can tell you that the mixer basically left him entangled or kind of spun around in the blades, and they were not able to get him extricated. These are actual pictures of the scene. He was awake and alert in a sitting position in the corner of the machine. He had a long-sleeve sweatshirt on and a hooded jacket. He was wearing leather work gloves, and his back was right up against the cylindrical wall of the mixer. Now, the mixer was located in a very large open warehouse area, so the heavy rescue people had good access to get in, but the problem was the mixer was actually up on a cement platform, and it was only accessible from 3 sides. So that was a problem. Now, this victim had his left leg bent under him, so his left leg was down here, and then his right leg was sticking straight up out of the top of the machine. His right arm was accessible, but then his left arm was behind his back, so they couldn't even get to that. And all 4 of his extremities were tangled in some way with these mixing blades, which were pretty sharp. And he didn't have any real sign of hemorrhage externally at all, but he was pale and he was diaphoretic. So they determined that if they had to dismantle this machine, they'd have to unbolt the drive shaft that the mixing blades were rotating on, and this thing weighed about 400 pounds. So they decided to get some hydraulic rescue cutters, and so as these cutters were kind of chewing through the blade, this whole container was like, shaking. And this poor guy inside was getting shaken up too. And it was making a lot of noise, and it was just kind of a chaotic scene. So they actually were speaking to the patient. He was alert and appropriate. They actually got the right arm, and they were able to see that the arm was uninjured, but the foot on the right leg was pale, cool to the touch, and they weren't able to get pulses. So they started an IV in the right arm and gave him some pain medicine and some Versed and some sodium bicarb just because of our crush protocol. And they hooked him up to pulse ox, gave him some oxygen, started to monitor his capnography. So now the question became, okay, now what do we do? And so Incident Command said, well, maybe we need to get a surgeon here. So the decision was made to request this since we didn't have a policy in place, we didn't have any real protocol in which to call, and we thought, well, it's going to take a lot of time to get someone there, so they requested a helicopter, but guess what? They weren't flying. It was snowing. Now, the rescue crew, in the meantime, was trying to cut some of these mixing blades away, but these blades were kind of close to the patient's face. And so it became apparent the only way they were going to be able to get this guy out would be to manually manipulate the broken extremities. And I'm talking about, trying to move these with several bones being broken in several places. And so the chain that controlled the direction of the mixing blades could be cut. They could reverse the direction of the shaft. The patient could be freed. So they decided to give more pain medicine, more sedation, to kind of be alert to the fact that it could depress his ventilations. And at that point, they were thinking about an intubation or some sort of surgical airway, and so they elected to nasally intubate the patient since he was sort of breathing on his own, and so they sedated him and were able to do that. So they passed the number 7 tube, confirmed it, gave additional medicines and some additional fluids. One firefighter had a good idea. He decided, well, let's get a forklift and we can put some pallets on it and raise it up to the backside of the container, and then we can kind of get into the patient a little bit easier. And so they went ahead and did that. They also passed some 2-inch tubular webbing around the patient to keep his head up, because his head kept falling into these blades. And so as they gave him more Versed and morphine, he was falling into these blades, so they did that to kind of keep his head upright. As the shaft was slowly spun backward, it was determined that the victim's left arm was actually wrapped completely around the shaft and back on top of itself. So they had to cut the jacket and the shirt and then try to rotate this to untangle the arm. Then the patient was slowly removed from the machine to the decking around the container where cervical spine immobilization was completed. And then they moved the patient to the medic, sedated, he was already intubated, splinted his extremities. The total extrication time was 1 hour and 25 minutes. He did well, but circulation was able to be restored to the one leg, and so it was eventually amputated. And the left arm was fractured in 3 different places. He's continued to do well. He's rehabilitated well. He came to our firefighter awards last November, was able to meet the crew that worked on him. And so, that's the way the feeling was. They were able to dodge the bullet this time. That's a picture of the mixer. So a lot of you know Battalion Chief Jim Davis. At that time, he was a captain. He was EMS 11, and he was kind of on the scene coordinating everything. And he was the one that basically called Grant and OSU. And it's not that they didn't want to help, but it was just that, hey, we're in surgery. It'll take us a while. How do you want us to get there? And so it was really kind of throwing all this together on the fly. And so it was destined not to really work well because it had never really been done before. So Jim approached me and said, and by the way, Jim tried to call me too. And naturally, I was down in Florida at a conference. So, Jim approached me afterwards and said, what are we going to do if this happens again and we can't get somebody out? And so we talked about it and we thought, we've got a problem here. Let's figure out a way to resolve it. And so that's what kind of started the ball rolling. And so we came to the realization that emergency plans must be finalized ahead of time to get a surgeon to the scene in the event that the type of entrapment or the patient's condition warrants such a drastic decision. We knew it wasn't going to happen that often, but when it did happen, we needed to have something in place, some sort of go-to plan where there's no question what we do next. So we decided to approach the 2 Level 1 trauma centers in Columbus, Grant Medical Center and the Ohio State University Medical Center. And we asked our chief, our fire chief, Ned Pettis, if we could go forward with this, and he enthusiastically approved the concept. And so we're very grateful to him for allowing us to go forward with this. And so we met with both of the Level 1 trauma centers back in October of last year. And I got to admit to you, I was kind of pessimistic and skeptical when we first met, because I thought there's no way in the world that the hospital attorneys are going to agree to this. I just, my darker side just, said, this is just too big of a litigation bite to take. And I was very, very thankfully proven wrong. We kept the group small at first. You know how things leak out? Columbus Fire's talking to Grant, Columbus Fire's talking to OSU. We kind of kept it small because the less moving parts, we thought the better this had a chance for success. So we wanted to keep it just with the Level 1 trauma centers, and we did invite Nationwide Children's, and they respectfully declined to be involved. So we were left with the two Level 1s, Grant and OSU. And we wanted to kind of keep it small. And we were very, very happy to find out that both of the Level 1 centers wanted to be a part of this system. And the next steps were for both hospitals to consult their legal teams. And, God love them, the legal teams need to look through every kind of thing and every kind of eventuality. And so it took some time. But I'm happy to report that we were able to overcome all of those legal hurdles, and we actually were able to come up with an agreement or an MOU with both trauma centers and the city. So we had to work with each hospital's legal teams and our city attorney's team. So this is the protocol. So the CERT, and sorry I couldn't come up with a better name. I know there's lots of CERTs out there, but Surgical Emergency Response Team is a resource that can be called upon by Columbus Fire EMS personnel when they encounter a person who needs procedures which exceed the capabilities of the EMS service, cannot be extricated and transported in a reasonable amount of time from the scene. So it could be someone trapped, could be someone who requires an emergency amputation, maybe they need blood, maybe they need a procedure right away, they can't wait for the ER. So we put our EMS officer, of which I mentioned we have 7, who will be the responsible person for activating the CERT by calling the FAO and asking them to be mobilized. Then the FAO will call the hospital ED on the red phone, which is the direct line into the emergency department, ask the team be activated, and ask them to prepare to be transported to the scene. Both OSU and Grant Hospital will have teams available, and so the way we set it up was 1 month, one hospital will be first call, and then another hospital will be second call. And so we keep our schedule at the FAO. So when the FAO gets the call and they've activated the team through the red phone, they'll send the closest available medic vehicle to that hospital emergency department to pick up the CERT and then take him to the scene. And once the paramedics on the transporting medic vehicle, they'll be responsible for escorting that team in a safe manner to the scene and keeping them safe. And then they'll talk to the incident commander and then introduce the CERT to the EMS officer so that there's a handoff of responsibility that we just wanted to formalize. Then the surgeon from the CERT, they'll assume control of patient care at the scene. They can, work with the EMS team and use whatever equipment and drugs and things that we have to help. And procedures outside the scope of our protocol, then the surgeon will be responsible for those, like an amputation. And then after they're stabilized at the scene, they'll be transported to the closest appropriate trauma center accompanied by the CERT. And this is just basically Grant's protocol. And it pretty much says pretty much the same thing. It specifies our responsibilities and then their responsibilities. And I'm just using Grant's because they didn't have OSU's available. And it just kind of goes through, their operational protocols. It's really interesting because you really don't have to take the whole OR when you do a scene response like this. It's a very portable type of, pack. So obviously everything is sterilized, but, you get betadine, battery-operated headlight, a jiggly wire saw, a scalpel, tubing, hemostats. And you can bring local anesthetics. Our EMS officers carry ketamine, so the surgeons were happy to hear that. And then, of course, we have Versed and fentanyl, morphine. And then they can bring blood or anything, antibiotics, things like that from the hospital. So we decided that once we had our MOUs in place, so the city attorney and the hospitals agreed upon an understanding or legal agreement that basically held harmless each facility if something like this happened. Each facility is self-insured, so we didn't really have to worry about that. And so, surprisingly, we were able to come to an agreement where the legal teams didn't put a roadblock there, but said, okay, if we adhere to these responsibilities and priorities, then we can do this. And I was just, amazed, but very, very thankful that we were able to come to that agreement. So we put together a dry run for the CERT, and we did that back in February of this year at the Jet Container Company. And we just wanted to kind of do a live run-through where we set up a patient that was entrapped in a machine, and I'll show you pictures in a minute, and make a call. And we let the hospitals know we're going to do it on this day so that they had a good idea what was going to be expected, since it was our first one. But, we wanted to have a thing where we set it up, we had the medics respond, we had the EMS officer on scene, they called the FAO, the FAO called the hospital activated the team was transported by our medic vehicle, they got there and they went through a simulation of what they would do in this particular situation. So we wanted them to bring the cavalry, bring the team they'd be bringing anyway, bring all the equipment with them, excuse me, and go through what it would take. And I think you'll see from the pictures here, we didn't make it easy for them. We gave them a pretty tough one to kind of think through. And so we went ahead and did that. And it was at that Jet Container Company down on South High Street. And we couldn't find a live volunteer, so we had to use a mannequin. But this is just showing the arm in that roller, and then that's a picture of the rest of it. And so, this was probably a good example of something that, we're not going to get that roller off. We're not going to be able to maybe reverse that flow and get that arm out of there. And so I thought it was pretty well thought out. The other thing to note is that the space here is very confined. And so, that was an issue because surgeons, they operate in pretty nice, sterile environments where everything is accessible. They have plenty of room to work around. But when they're called to the scene of something, it could be in a really hairy type of, environment. And it could be very closed, and, they might not have enough room to get the team back to. And so we wanted to kind of give them that feel because they'd be really off their turf and maybe outside their comfort zone. And that's one of our rescue personnel, and as you can see, what we saw anyway, is when you get rescue personnel, fire personnel, medic personnel, and then a CERT on top of that, all around this patient with maybe about 12 inches of space to work in, it becomes a real, interesting situation. People are tripping over each other. People can get injured just from the response to the scene. They had wires running, not wires, but kind of cords and cables running across the floor. There were like conveyor belts that you had to walk across to get to the patient. And all these things you never even think about when you talk, think about a scene response like this. And so this is the team arriving. This is the Grant team. OSU came in the afternoon, but we basically got pictures on the morning session. And that's Dr. Paul, and that's his team. And they're going, see those conveyor belts there? I don't know if I can, oops, now I did it. Oh, good. I thought I had a laser pointer. Anyway, the conveyor belts are down there, as you can see. And, you know, our EMS personnel were able to start an IV and have some of the stuff done before the CERT got there. And this is them. They've got some blood there. And as you can see, it's a pretty crowded space. That's Dr. Paul. He's getting ready to go back there and evaluate the patient. And he's trying to kind of give some direction to the team. Well, you know, he went ahead and did his thing. And then we were fortunate to have a recruit who we could make do anything we wanted pretty much. So we had him be the patient and simulated actually taking him out and having his arm behind him as if it was amputated. He wouldn't allow us to amputate his arm, but he did put it behind his back at least, so that was good. And then again, just taking the patient out through this very closed space, and then going through. I don't know if this will work or not. I don't know if you can click that on. So we're here at Jet Dry Container to simulate an actual situation where one of the workers has their arms entrapped in a piece of heavy machinery to test out our first deployment of our surgical emergency response team. We have our rescue personnel here along with our firefighters. We've just made the call to the surgical emergency response team. They should be arriving momentarily to go ahead and provide definitive treatment for this patient who has the entrapment injury.
Okay, some of the challenges when a rescue company would have arrived on the scene, the victim was caught in a machine. He had to be stabilized in a standing position, so there wasn't any weight on his arm, which was caught between the rollers. So that was the major challenge right there. And then plus getting the IV into the patient and oxygen on him before we could even start the extrication procedure.
What we were going to do is disconnect the top roller. We got to get that roller stabilized so when we do cut it free, it does not drop at all. So we've got it supported with cables and a come along. So when we do cut it free, it holds it in place, and at that point we could actually raise it up to give us clearance to get the victim's arm out.
That's the EMS supervisor kind of going over the run.
Fentanyl and Versed, okay? Give them 5 of Versed and 100 more of fentanyl. Actually, I can get over there. I'll go over there. Well, still picking off.
That's how close the quarters were back there. He had to go under the big rollers and.
Frank, you got the gig lead?
They're just getting ready to do the amputation, or at least simulate it.
There you go.
Medic regular crew, another medic and a driver.
Alrighty. Going up and over. Alright, so we need to make sure we're checking vitals and mental status during all this.
You ready?
Yes.
You see all the different things they have to take the patient over and around. Grant brought 2 people along with the surgeon, so that a total of 3 folks. After our surgical emergency response team exercise is completed for the morning session, and we have Dr. Doug Paul with us, who's the medical director for the trauma program at Grant Medical Center. And Dr. Paul, you completed the exercise here. What kind of challenges did you find with this particular patient?
Well, you know, Dr. Kessick, the challenge for us as hospital personnel is coming into an environment which we're not comfortable with. We rely very heavily on the firefighters and paramedics from your department to keep us out of harm's way and get us to the patient appropriately. Once we're here, then we have to deal with the position of the patient, being able to evaluate them in the current position that they're in, and then making a decision of life versus limb, which is what it came down to today.
Right. And in this confined space, I'm sure you found it somewhat difficult to be able to do the typical things that you do in the operating room in such a small space. How did you overcome that?
Well, I just had to figure out how to get back under the machine and to the patient. And at my age, quite honestly, getting through those tight spots isn't as easy as it used to be. But got back there, and then my team stood on the outside, and we worked across from each other and made the best we could of it.
Okay. What kinds of things did you bring with you to the scene to use as far as any kind of surgical procedures that you needed to do?
We were prepared to perform a surgical airway if need be, to put tube thoracostomies or chest tubes in, and then to do an amputation of an extremity. So we brought hemostats, Kelly clamps, a giggly saw, things of that nature, and then sterile dressings to dress the wound with and transport them back to the operating room. We would go directly to the operating room with this patient so that we could continue our stabilization evaluation process and clean out the wounds and dress them appropriately.
And in this patient simulation, you had to do an amputation of an arm. So how much time does that normally take in an emergency situation?
We probably can get that arm off in about 5 minutes.
Wow, so 5 minutes. Because during the exercise, once you folks got here and got in place, it didn't really take you much time to actually do what you needed to do, take care of the patient, and get them transported to the hospital. So it really doesn't mean that since you're coming to the scene, you'll spend an inordinate amount of time here at the scene. Is that correct?
Yeah, the decision to proceed with amputation is going to be based on what the extrication team tells me and what the paramedics tell me about the patient's status. If the extrication team is unable to get the patient freed, or the paramedics tell me that their status is declining with lower blood pressure, oxygenation, things of that nature, then we're pushed to move more aggressively.
All right. So I guess our plans for implementation, just want to go through that with you. We went live actually April the 4th, so it's not been a whole lot of time since this has been in place. And again, each hospital alternates, so one takes first call, one takes second call, and then they flip. And we'll do another drill probably sometime this year, I would imagine in the fall. And we probably won't give as much notice to the hospitals this time, and we'll see how the response is. And of course, we hope and pray we never have to use this, but we're glad that now we actually have something in place here in Columbus where if something did happen, well, we know exactly what we're supposed to do, at least within Columbus Fire. And I do plan on talking about this to our COTS pre-hospital committee next week, because if things are dispatched through our alarm office, then the MOU is operational so that we anticipate that if other EMS systems would like to activate the CERT team, we should be able to do it if we have an agreement with those EMS systems. So we're going to start that conversation next week within the forum of COTS to see how we can bring other systems into play so they can take advantage of this. And we think, you know, if you build something, if you make plans for it, sometimes something will happen and it will just prove the wisdom of actually doing it. So I guess the bottom line is, you know, it can be done. We were able to do it. And I've had calls from all over the country now about how we did it. And again, we're fortunate here in Columbus because we have a good group of hospitals that work well together. They are competitors and they're trying to get market share, but by and large, as evidenced by the STEMI system, as evidenced by the stroke care we're giving, I think that the bottom line for them is that the patient comes first. And so we did learn that legal barriers can be overcome. The trauma centers do want to play. And when we started this, I don't know, at Grant at least we heard this, and I believe at OSU too, there was a tremendous amount of positive buzz that occurred when we put this in place. There was a really good feeling about what we were doing because you know how you have your one silo that's EMS and you have your other silo that's the emergency department in the hospital. Well, we were bringing those two cultures together. And I think that the more we do that, the more we will be able to work effectively together, EMS and hospital personnel. If hospital personnel can appreciate the challenges EMS has, and EMS can accept and appreciate the challenges that hospital personnel have, then I think it helps all of our jobs to go much easier, and the patient benefits from that. So these kinds of cooperative ventures, I think, have a lot of other wonderful benefits that spin off, notwithstanding the advantage to the patient. The community, I think, will see it as a positive. They should, especially if something like this happens and we end up saving a life because the CERT was activated. So the patient's best interests are definitely what matters, and that's what helped to move this whole process along. So I'll be happy to talk to any of you at lunch or during the remainder of the conference about this, and certainly appreciate your kind attention. Thank you very much.
Welcome back from lunch. If everyone could come in and have a seat, we'll get going on our afternoon session. This afternoon, we're proud to welcome Dr. Kevin Pugh, the mangled extremity. He comes from Grant Medical Center. He's a director of limb reconstruction, orthopedic trauma, and reconstructive surgery from Grant Medical Center, Dr. Kevin Pugh.
It's great to be here. Didn't know if I was going to make it. I was busy doing clinic this morning and finished just in time. So you might want to know what limb reconstruction is and how it differs a little bit from orthopedic trauma. Limb reconstruction, I think, really can be whatever you think. It's all things to all people. And at Grant, we have a limb reconstruction center that really works on the comprehensive and integrated management of all extremity problems, really regardless of their etiology. Has multiple interrelated specialties, and really we're going to talk this afternoon about acute trauma, but we do a lot of post-traumatic reconstruction, and a lot of what we do is orthopedic trauma, and so I'm an orthopedic trauma surgeon, and we take care of a lot of things: non-unions, malunions, bone loss, and mangled extremities. We've got great support from our plastic surgeons, and most of what I'm going to talk to you this afternoon about wouldn't be able to be done without our plastic surgery colleagues, our vascular surgery colleagues, and the internal medicine and radiology support that we get. So the goals when you bring in a mangled extremity, at least my goals for the patient, are that we want to return that patient to have a functional extremity so that they can return to their avocations and their occupations. We want them to return to work. We want them to be satisfied with the outcome, whatever that might be. We'd like them to have no long-term pain, and we'd like this to all be done in a cost-effective environment. And as we do that, you know, there's certain injuries that are very bad, and you know that when you bring those into a hospital, these are those sort of spectacular ones. We want to try to identify those people that can be salvaged and those versus those people that can be amputated. And the people that needed to be amputated, we kind of like to identify those people early so that we can obviously reduce pain to the patient, not head down a path of reconstruction that then has to be aborted, but to get them on and get them about their way earlier on. So we'd like to try to sort out on these mangled extremities those that can be saved and those that need to go. And really, you kind of borrow that from the clash, right? You know, should it stay or should it go? But really, that really is going to be the theme of today's talk. So our objectives today are to look at decision-making in severely injured extremities in the blunt trauma population, to a little bit about evaluating these people with a limb-threatening injury, what some of the outcomes of these injuries are, and then we've already talked a little bit about some of our local capabilities. What we're not going to talk about are replants, not isolated, sharp upper extremity problems. It's a little bit of a different problem. This is sort of a specialized indication. You know, replant indications, as you all know, these are isolated, sharp, small zone of injury type problems that can be put back on. And I'm not going to deal with that. I'm going to look something more like this. And this is obviously not a replant candidate. This is sort of arm to auger, and it ends up like this, can't even close it on the first night. So we're going to talk more about this kind of thing. These are injuries where replantation, at least in the upper extremity, and certainly amputation in the lower extremity are more appropriate. These are severe crushing injuries, amputations at multiple levels, amputations in severely injured or ill patients, long warm ischemia time, or tip amputation. So these are the sort of injuries we're going to be talking about in the upper extremity. In the lower extremity, you know, here's an open tibia fracture. And what we're not going to be talking about is the cute open tibia fracture. We're going to be talking about the ugly open tibia fracture. And then, of course, everything in between. So limb salvage, when we can do that, is really a complicated process from when the patient comes in. It involves both amputation, that's one way to salvage a limb, and reconstruction, which is what I like to do and we do well. But when you try to make the decision as to whether the sort of limb needs to stay or should it go, you need to consider who the patient is, what the injury is on that patient, what their other injuries are, and the team you have taking care of them. So when we look, you know, this is a patient with an injury, but it's also a patient that has a medical history. Some of these people are sick. They have diabetes, they have COPD, they have different activity levels and expectations, they have different levels of social support, they're on different medications. The same injury in a healthy 22-year-old is going to be treated differently than the same injury in a 57-year-old diabetic with marginal renal failure who smokes 5 packs of cigarettes a day. So part of our plan is going to definitely involve our host. You got to carefully evaluate the patient, looking at the skin, the muscles, not only the muscles being present, but the muscles functioning, nerves, their vascular situation, bones, everything around and about that patient to sort of develop a personality of this injury, encountering not only the patient, where they're at, who's taking care of them, and the injury itself. Because teamwork really is essential. It does take a village to take care of these people. You guys are sort of the guards to the gate, so to speak, and I sort of live in the middle, but pre-hospital care is very important in managing these people. Members of the team have to be available in a timely, cooperative manner. You need to talk to us, and I really like it when I can talk to you guys. We have to have all the right equipment to take care of these people, and so it really does take a good team. It's been shown in a lot of data that trauma centers are really important in taking care of these limb salvage patients. There's been a variety of data developed, and I'm going to show you some of that, which really shows that the most important thing in taking care of this mangled extremities is the time it takes to get to a trauma center. And the trauma centers really are important, and people benefit from care in the trauma center because some of the biggest things are, can the patient be covered? And if they can't have soft tissue coverage, they can't be saved. So this is actually a nice published finding, and that level 1 trauma centers do provide an important aspect to the care that's really negligible for lower energy injuries. In terms of how many of these people get infected, you can see at the bottom that there's really no predictive thing or predictive value in terms of infection to the time when we first get them to the OR, the time that they're admitted to the time that they get to the operating room, how long it takes from when we debride them to covering them. The most important thing about getting them, about infection is how long it took them to get to a trauma center. So it's really important. in terms of pre-hospital care, you want to relocate dislocated joints. And I think it's important that you feel comfortable just taking the leg and making it look like a leg again. It takes the pressure off the skin, it takes the pressure off the vessels and the nerves, so it's perfectly okay. Reducing those dislocations is very helpful. In this case, a dislocated knee or a dislocated hip. Those kinds of things are very helpful. We want to initially stabilize the injury in a temporizing fashion. That's something that I'm going to do. And then, whether it's a spanning fixator on the knee or around the pelvis. And then the next step is we're going to decide what we're going to do with the patient. This is obviously a situation in an adult where the limb gets to stay off, but sometimes it's hard to determine what we should do with the limb. And the issue really is soft tissue coverage. There's a tremendous amount of things we can do with the bone, but if we can't provide soft tissue coverage, then we can't salvage the limb. So the reason this is a big deal in the tibia is a subcutaneous bone. The anteromedial border is subcutaneous. There's very little protection there. That's why it's easy to get an open tibia, but it's also why it's really hard to cover an open tibia, because the bone is so subcutaneous. We've made a lot of advances in limb salvage. That's really annoying. In terms of bone reconstruction, in terms of neurovascular reconstruction, and in terms of wound coverage. In terms of bone reconstruction, we've developed a lot of biologically friendly techniques utilizing external fixation, utilizing nails, and utilizing minimally invasive plate techniques, as you see below. Here's an example of a patient who took an AK-47 to the mid-tibia. It turns out he was dating a girl whose brother was a nocturnal pharmaceutical sales representative. Unfortunately, they came home one night and interrupted a business transaction, and this guy was really in the wrong place at the wrong time. You can see that most of the middle of his tibia is gone. It's a huge soft tissue wound. So we temporized that initially with an external fixator. The guy went on to get a free tissue transfer. Again, coverage being the most important thing, until we had a bony defect that looked like this. So we had excised about 14 centimeters of his tibia. Next, we got to figure out a way to take care of that. And we did a bone transport operation where we actually do an internal lengthening and move a piece of tibia from down below up to fill the defect. Here's the patient as we go. You can see above, I don't really have a pointer here, and you can see that new wispy bone forming as we've transported that bone from below by the ankle up to fill the defect. It consolidates, and there's a union. And so we've been able to salvage this guy's limb really because he ended up in a trauma center and he could get good soft tissue coverage. And we can do that actually as a multifocal operation and transport from multiple levels at the same time, so it gets to be fairly fancy. We've also done a lot on not only with bone transport, but with bone grafting techniques. So we've got all kinds of new techniques in terms of where we can harvest bone graft, how we can harvest it, bone graft substitutes, and utilizing spacers and induced membranes to provide vascularity to our defects. Here's an example of a motorcyclist from the central Ohio area who was down in West Virginia taking care of at the University of West Virginia with this bad open distal femur fracture. You can see that they've temporized that initially the first night with an external device, packed the defect with a big bunch of bone cement just to manage the dead space in the wound, and then the patient was transferred back to central Ohio like this. They stabilized the tibia fracture, stabilized the end of the femur, and packed a big cement spacer into that defect. Spacer does two things: manages dead space, provides a little bit of stability, but also allows the induction of a membrane around that space so that when we come back later and fill that space with bone graft, it makes nice bone and the patient goes on to a very nice union and return to function. So there's a lot of fancy limb salvaging techniques that we have now. Neurovascular reconstruction is improved as well. We can either directly repair the vessels, we can graft in terms of repairing vessels and nerves, we can provide shunts temporarily to allow the limb to still have circulation while we provide some bony stability and then later go back and do it. And these are a variety of things. Wound coverage has also taken a tremendous advance in terms of skin grafts, which we all know are pretty simple, all the way up to free tissue transfers, where we actually take usually a piece of latissimus out of the back or a bit of rectus out of the abdomen and are able to put those in a different position, sew them in, and provide coverage. And so this is where we rely on our plastic surgeons a great deal. So we can do a lot of amazing things in terms of trying to salvage somebody's limb. And so it's always hard when somebody comes in to decide, well, you know, I can probably give it a go at reconstructing the patient, but the answer really is, should we do that? Because there's a lot of people that can get on about their business right away. If you just cut their leg off, they can get into a prosthesis. They can get back about their life in 3 months versus a year and a half it may take in order to fill this big bony defect and get a free tissue transfer and deal with the complications in the middle. So in the issue of how we have, can we do it, you know, most of us would say, well, I'd love to have my leg, but there's been a lot written about this. Sigvard Hansen was a director of orthopedic trauma at Harborview Hospital in Seattle, which is a huge trauma center in the Pacific Northwest. And they found out with their limb salvage patients that, you know, many people lost their jobs. They were off work for over a year. Their families, they went broke. They lost their savings, and most importantly, some of their self-image and self-respect, because they became sort of a professional patient. And so although their limbs may be saved, their lives were really ruined in the process. Lisa Canada, who's currently in St. Louis, wrote that patients can unwittingly enter a cycle of financial burden, addiction to pain medicine, adverse effects on job performance, and feelings of not contributing to, feelings of not contributing to society, based just to the fact that sometimes these reconstructions can take, you know, upwards of a year. So how do we know who's going to benefit from a reconstructive procedure and who's going to benefit from an early amputation? What can we tell our patients? Especially in light of this. This is all over the television, right? You've got sprinters who can't compete in the Olympics because people think that they may have an actual advantage because of some of the prosthetics we can put on. You know, we have advertisements with people playing basketball and bilateral lower extremity prostheses. So people get the idea that we can do this quite a bit, and maybe this is the way to go. So what are the absolute indications for taking off a limb? Well, let's see if we click that. No, 2 pictures didn't show up. Let's try it again. Complete disruption of the tibial or sciatic nerve in an adult patient. So if those 2 nerves or one of those nerves is disrupted, the patient's going to end up with an insensate foot that will never be sensate. And if they're coupled with a mangled foot or a mangled tibia that's going to take a long time to recover, we can restore continuity, but if they can't feel their foot, it's not going to be as good as a prosthesis. If you have a crush injury or a severe soft tissue loss with warm ischemia time of greater than 6 hours, so the patient has been dysvascular for more than 6 hours with a crushing injury, not one of those discrete amputations we talked about, but with a crush injury, you probably ought to go ahead and let the thing be dead. Unreconstructible bone or arterial injury. I'm going to show a couple of cases of those. These are cases where we just cannot put the bone back together again, or our plastic surgery colleagues cannot cover it. Because if we can't provide soft tissue coverage, you really can't salvage the limb. And again, loss of plantar skin or soft tissues. In this case, as you can see, unfortunately, the top 2 pictures aren't progressing, with somebody that got run over by a train and basically degloved their foot. And that actually is the degloved skin right on there on the bottom of the slides. So we're able to salvage very damaged limbs, but should we? These are very difficult operations. It's a series of operations. Usually I tell people it's a process, not one procedure, not 2, but it may involve several. It's time consuming, it costs a lot of money, it's fraught with complications. Most of these people will go on to some sort of a fracture that doesn't heal the first time. A lot of them get infected, and some of that is osteomyelitis. They'll have wound problems, so even if we can put a flap on them, oftentimes they need to have that buttered up a little bit. They're on pain medicine for a long period of time, and depending on the series that you write about, 9 to 40% of these people need to eventually be amputated anyway. And it's not a small number of people that may go on to have a mortal injury from one of these mangled extremities. So what is a successful salvage? How do the patients function physically? I mean, that's a good answer, right? So if you have somebody with an isolated single extremity injury below the knee, you probably can get them to function physically pretty well. But a lot of it is how do they do psychosocially? Some people can't see themselves ever without their own extremity, and some people just want to get on about their business. You know, can they return to contribute to society, or are they going to be sort of a disabled person forever? And a little bit of this is how we determine what's successful and what's not. It's not just whether we made the thing heal and live. And you know, how do these people do in terms of salvage versus amputation in terms of function? I mean, these are the people that they're actually comparing themselves to, because this was the other alternative. So, how do we determine who's going to most likely have success and who's going to do better? Well, some of the criteria might be like this. If the patient has to be carried over rough roads, the bones are comminuted, the patient's in great pain, you know, if there's bad injury to the soft tissues, if there's extensive lacerations, if the nerves and arteries are involved, and if the fracture involves either the knee or the ankle joint, maybe they ought to be cut off. These are the Civil War criteria for getting an amputation, but the thing about it is, if you really look at those, they aren't a heck of a lot different than where we are in 2011. Maybe phrased a little bit differently, and we have a lot more technology, but some of the same issues are there. So what's happened over the years is, in order to try to determine who should be amputated and who should not, we've developed a whole lot of scoring systems, and they all have names, the MES system and the, I mean, it's just the alphabet soup. The problem is that as we've done research on all these methods, none of them are accurate. So we can't have our pre-hospital providers out there assessing the patient and giving a score to these people and calling in and saying, you know, I got a guy out here with a MES score of 4. You know, and if I have a MES score of 4, with that particular system, I was going to need to amputate the leg. The problem is that we found that none of these are predictive. And so we needed to have another way. So in the mid-90s, a National Institutes of Health study, the Lower Extremity Assessment Project, was started by the NIH. It's called the LEAP study. And what that is a multi-center, 8 level 1 trauma centers in the United States and Canada, looked at 601 patients prospectively. And these were people with very high energy fractures below the distal femur, so involving the end of the femur, the knee, and below. And they tried to look at these people prospectively to see whether they were amputated or whether they were salvaged. And then they followed them afterwards in terms of function, in terms of sickness impact profile, costs, and a variety of data. And this particular study has probably generated at least 50 publications and has been extremely helpful in the management of people with mangled lower extremities and trying to determine what we should do. And you might say, well, did it answer the question for us? And the problem is, no, it actually muddied the waters. So the outcomes of the LEAP study were in terms of physical disability, return to work, psychological issues, and patient satisfaction, complications, the utility of these predictive scores, and costs. And what have we learned? And I actually participated in as one of the centers when I was doing my fellowship. And what have we learned from the LEAP study? Well, no matter what you did, 42% of the people that you treated, either amputated or didn't, had severe disability 2 years after their injury. And 49% of them had severe disability 7 years after their injury. So they didn't get better, they got worse. 53% of people that got amputated returned to work at 2 years, compared to 49% of the people that got reconstructed. Psychological outcomes show no difference between amputated patients and limb salvage patients. You know, still a huge number of them, mid-40s, 42 to 48% screen positive for psychological disorders. 20% reported severe phobic anxiety, PTSD. 20% reported depression. 66%, however, were satisfied. They thought everything that could be done was done. And they found that really this wasn't satisfied or statistically correlated with whether you amputated the patient or whether you reconstructed them. It was more related to physical function, pain, the absence of depression, and whether or not they were able to return to work. In terms of complications in the limb salvage group, they had more complications. They had more late complications, so not just initially, but 1, 2 years later. And there were many more additional procedures that were done on these patients that were done on the amputated patients. And 10% of them required late amputations. And of those, 85% of them had complications. In the amputation group, it wasn't all a picnic. 34% of the people that got amputated ended up with an infection. 13% of them had wound problems. 13% of them had long-term phantom limb pain. And 15% of them had to be revised. If we look at overall issues in terms of limb salvage or amputation, you can see that the costs are very similar. If we look at buying the patient with an amputation, a prosthesis, you can see in the red on the lower end, $12,000 for a prosthesis. It turns out if you salvage a patient, even with their multiple rehospitalizations and multiple procedures and days in rehab, the amputation and the limb salvage cost just about the same. However, if we account for long-term costs, meaning a new prosthesis either every 2.3 years or every 5 years, you can see that people that got limb salvage procedures were much cheaper than people that ended up with amputations, even though their initial care may have been more expensive. So this is also something to factor in as we make some of these societal decisions that may be coming down the road. We also proved from the LEAP study that none of these scoring indices could be proven valid, and that the presence of tibial nerve function, now I said function, not continuity, was predictive of whether or not salvage or amputation was appropriate. So just the fact that the patient comes in with an insensate foot does not any more predictive of who should have which procedure. Factors that were associated with poor outcomes, right? 66% of people were relatively satisfied. And is there a physical factor that can be used to predict a poor outcome? Well, actually, no. The things that you would expect that have really nothing to do with their injury are the ones that are predictive of outcomes. So older people, people that unfortunately are females, and I'm not sure why that is, non-white race, lower education, poor households, people that smoke, people that have low self-efficacy to start with, people that are in poor health, and people that have some sort of legal situation that might promote secondary gain, are the people that didn't do as well. So it didn't have really anything to do with their injury. So what do we do? If I've shown you this big 600-patient, multi-centered, randomized prospective study with level 1 data, all we've done really with this LEAP study is we've clouded the waters. We thought we were being able to predict, based on all of those alphabet soup studies, who should be amputated and who shouldn't. And really right now I can tell you that we really don't know. And so the thing we do is we exercise our best judgment when we talk to the patient and look at their constellation of injuries and look at who they are and go back to the whole it takes a village thing and see what we can do. So what do we do? So unless it looks like this or this, there's no easy answer. You know, injury severity scores are not reliable. Functionally, patients do equally as bad. I shouldn't say equally as good. They do equally as bad with amputation and reconstruction. The salvage pathway is longer and more involved with more complications and more procedures, but the amputation pathway is certainly more expensive in the long term. So in terms of decision making, we use our clinical judgment. It's a multifactorial issue. You know, we look at, again, their injury characteristics, bone injury, soft tissue injury, muscle, nerve, vessels, ischemia time. And I'll tell you, of those, the most important thing is to whether or not they can have soft tissue coverage. You know, the patient characteristics are important. Sometimes the host is the deciding factor, and sometimes it's the hospital's resources. And again, as I've shown you, level 1 trauma centers provide a statistically significant improvement in this care. Certainly the surgeon skills are important, and you have to have some experience in taking care of these patients, and then managing the patients' and families' expectations. Some people are very clear in how they want to decide these things one way or the other, and other people really spend a long time trying to decide. So what we have to do is we have to inform the patient, because you're going to get one of these two situations, right? Why'd you cut my leg off when you said you could have saved it? Versus, why'd you put me all through this crap when you could have just cut it off in the first place and got on with it? So as this patient says, maybe you should consult your lawyer to get a second opinion. We're just going to take you through a couple of cases here. Timing really is everything on these people. This is an example of a guy who was involved in a big accident. He has this very large open femur fracture. It's got a large degloving soft tissue injury, a lot of devascularized vastus lateralis. Patient's got a spanning external fixator on, and we've let the patient's injury evolve and their soft tissue injury evolve. This is their x-ray initially. You can see that the fracture itself is not the big deal. It's really the soft tissue injury. You go in and debrided everything that doesn't look good, and you can see there's a very large shark bite in this patient. You get more information. Again, it's just a fairly straightforward lateral femoral condyle fracture. Second look, more muscles gone, debrided, got a VAC dressing on. And the issue here really is, can the patient be covered? After the third look, the wound was deemed by the plastic surgeons not to be coverable, and so the patient was amputated. Here's an example of something that we deal with sort of on a regular basis. It's a 38-year-old motorcyclist. You can see a tremendously comminuted tibia fracture with a huge wound. Here's the x-rays. You can see that the patient also has a fracture at the end of the femur, in the mid-shaft of the femur, and of the femoral neck. The patient initially, that wound was, or that tibia fracture was amputated through the knee the first day. The femur was salvaged and reduced with an external fixator that went from the pelvis to the femur to the distal fragment. Eventually the femur was fixed, the patella was put onto the end of the leg. The patient is probably not happy, but definitely is healed and has an extremity that can be salvaged. So that really concludes my remarks. I realize that I haven't filled all 50 minutes, but really the issue for us is there is no deciding factor on whether people should be reconstructed or whether they should be amputated. It's a local case level thing. With that, I'd be happy to entertain any questions. I'm told there are microphones out there. All right, nothing like the first talk after lunch, huh? Most of you look to be awake, though. I am with these lights on. Yes, sir, I think, here we go, there's a microphone coming.
I know it was just one bullet point on one of your slides, but we push it at our trauma center pretty big. How important is the instructions to not smoke after reimplantation because of its effect on the microvascular regeneration?
Well, reimplantation or non-reimplantation, smoking is a bad thing. It takes, it has a higher demonstrated incidence of non-union of the bone, of wound healing issues, and really it just takes 3 cigarettes a day to provide enough nicotine to have vasoconstriction to supply that effect. So 1 cigarette every 8 hours will do it. You know, that being said, you know, a large number of our patients smoke. I think there's a higher incidence of smokers in the trauma population. And so these people, some of them have been smoking for years, and it's an addiction, and it's really hard to quit. And you know, you have to deal with what you have. You tell the patients they're at high risk, they have a higher incidence of these problems, and you ask them to quit, you ask them to cut down. But yeah, it does play a big role in what we can do and the success of what we do.
If the patient has an injury to the hand, does it matter what dominant hand it is, if you would be more likely to amputate or salvage?
I'm sorry, I didn't catch that again?
If the patient has an injury to the hand or arm, is it more likely, if it's their dominant hand, you would try to save the extremity, or would that even factor into it?
Well, I mean, it may for people that actually are a replant candidate, but in general, it doesn't matter. You know, if it's your dominant hand, it's nice to save it, but certainly having something that doesn't move and you can't feel is not that helpful. You know, the lower extremity does better with an amputation than the upper extremity, simply because, you know, the hand is the business part of our upper extremity, and really the rest of it is just geared to put the hand in position in space so that you can do something with the hand. So in the upper extremity, because it's a non-weight-bearing situation, you're going to be more likely to be able to salvage an upper extremity than you are a lower. So for the same degree of injury in the lower extremity and in an upper extremity, you're probably going to be able to or want to try to salvage the upper extremity, because certainly with a prosthetic, the lower extremity can be salvaged a little easier, or function can be restored a little easier. Does that answer your question? There's one in the back row. Right there.
In the consideration of trying to determine amputation versus salvage of a limb, how much does patient compliancy play a factor in that decision?
Well, you know, if we knew these people before they got injured, it would probably matter a lot, and that's what makes it very difficult to try to make some of these decisions. You have to try to get to know your patient in a pretty short amount of time, because when you take care of trauma patients, you know, a lot of these people come in and you don't know who they are, you don't know their name. Some of them are head injured and they can't tell you. So you have to try to make a lot of assumptions based on their injury. But a lot of the times, so what I'll do, somebody comes in with a very difficult situation, we take them to the operating room, we wash out their wounds, we provide some stability, we dress their wounds, and then based on your survey of that injury and the x-ray and what you do is you go up and you have to sit down in their room and have a pretty long discussion with them about, what they're looking at. And it's hard. You have to try to get to know your patient in a very short period of time. Now, compliance means you've told them to do something and they haven't done it. So it would be nice to know if these people were going to be compliant beforehand. So I guess I usually give them the benefit of the doubt as we move along. But there's some things you do know. You can find out about what their goals are. You can find about their support system at home. You can find out what kind of job they do, what kind of function they like to return to, what kind of diseases they have, if they smoke, if they're nocturnal pharmaceutical sales representatives. And all of that sort of plays in and gives you clues as to what kind of compliance they might have. I mean, I'll tell you that I've, amputated people that you would think are normal, everyday, average people that, don't come back to see and won't do what you say. And we've also done some really nice salvages on people that you'd think would be borderline type patients that really have done a great job and come back to every visit and done everything you've said. So these, it's not, I don't have the benefit of getting to know somebody like you would before an elective procedure. All right, nothing from that side of the room, I guess.
Are there any changes that you see as forthcoming or would like to see forthcoming in the pre-hospital management of this sort of wound?
Things that are forthcoming or that are possible pre-hospital for these kinds of people? Did I get that right?
Yeah.
Okay. Well, pre-hospital, the one thing that I really don't like to see is when the patient comes in completely strapped to the backboard with their toes pointing directly at their rear end because they were, quote, more comfortable that way. The best thing that you can do for the patient actually is to take their leg and make it look like the other leg. Toes pointing straight up and straight. And a lot of folks will say, well, I'm really nervous about kinking vessels or kinking nerves or what have you, but what you're really doing is just restoring the normal shape of the leg, and you're taking the kinks out of the vessels and you're taking the kinks out of the nerve, and you're not pushing the fractures right up against the skin so that we end up with pressure points. And so, I'm sure that good fluid resuscitation, keeping their blood pressure up, allowing the tissues to perfuse is important. But just making the limb look like a limb. So splinting them in an anatomic position if you can do it. Obviously, you try to straighten out the leg and it's not going. They probably have a fixed dislocation. But the more you can return their extremity to a normal looking appearance and just kind of splint them in that position was really helpful. Yes, sir.
One more question. We were going through our orders a couple months ago. I pulled the pre-printed orders, and our orders for an amputation say to give the patient, even though it's fairly contraindicated in most trauma patients, aspirin to salvage and to make a limb more salvageable. Do you have any comment on that?
Oh, so in a patient that might be looking at a replant, you say?
Yeah.
To give them aspirin? Well, all that does is anticoagulate them a little bit. And when you're dealing with somebody that does replants, what the aspirin is doing is it's sort of making the blood a little thinner. And because one of the biggest issues when you're trying to restore circulation to some of these people with the small vessels is they'll clot off early. And so what you're doing is you're sort of setting these people up for a better microcirculatory environment early on. In the mangled sort of limb, that's not going to help you at all because we're looking at macro circulation. Okay, anything else? Well, thank you very much. You'll be commended for staying awake, and thanks for having me.